Hello, everyone. I think now I am alone here. No viewers. I was ready to say this, but it is like my repetition of such webinar, and I would like to share my presentation thanks to Cambridge Prescribers Guide in I'm so sorry for my pronunciation. I am not a native speaker. So, uh, our today's topic is carbamazepine, the drug of choice, carbamazepine. Okay, so my pronunciation will be not good. Sometimes I will make mistakes, or maybe most of the time I didn't know, to be honest. Anyway, I'm Inga Golub, an early care psychiatrist from Sumy city. Sumy region is another eastern part of Ukraine. So I would like to share this presentation with you due to my huge desire to share psychopharmacological knowledge. So let's move to the next page of this presentation. To be honest, this is my first webinar in English, and I feel a little bit how to characterize this moment. I don't know. So just let's try. Today I am a risk taker. So carbamazepine. So carbamazepine was discovered in 1953 by Swiss chemist Walter Schindler. It was first marketed in 1962. It is available as a generic medication, and it is on the World Health Organization's list of essential medicines in 2023, by the way. It was the 185th most commonly prescribed medication in the United States, with more than 2 million prescriptions. I don't think so that in Ukraine there will be a big difference. So in Ukraine we have the same situation, and this drug is really popular in psychiatry field, in neurology field. That's why I choose this drug as a mood stabilizer. So you will just click on the playlist like mood stabilizers, and can watch this webinar or just read this presentation by clicking different slides. So, historical and discovery stages, just small moment. Synthesis. I'm so sorry for my pronunciation. Synthesis. I have, by the way, such list of pronunciations, how to pronounce some of the terms, and synthesis, as I understood. So carbamazepine was first synthesized. Oh my God! Now by Swiss chemist Walter Schindler in 1953. Discovery of anticonvulsant properties in 1957. Researchers discovered its effectiveness in preventing seizures. First clinical approvals, it was first marketed as treatment for trigeminal neuralgia. I'm so sorry for my pronunciation. That's a challenging term for me. So in 1962, and later approved for epilepsy in 1965. Oh my God, Japan. A huge chapter in the history of the drug began in the 1970s. Japanese scientists Takizaki, Hanoka, and Okuma discovered that carbamazepine acts as a mood stabilizer, which allowed for its successful use in the treatment of bipolar affective disorder. Around the same period, during the 1970s, the drug also entered medical practice in the former of USSR, where it became widely known under the brand name Philipsine. By the way, in Ukraine, this brand is also available now, and it's like a popular Ukrainian brand. So Irina is my Ukrainian medical intern, psychiatrist. She's asking now at which time our webinar is starting. So I will reply to Irina. I can't imagine that even 3 students or 3 viewers now are watching this webinar. To be honest, that's a great result for me because I was thinking like zero viewers I will have because it's like my first repetition of such a psychopharmacological webinar. Psychopharmacological. I'm so sorry for my pronunciation again and again. So let's move to the next slide. To be honest, what about the class, pharmacological class of carbamazepine? Anti-epileptic drug, it's first class a drug with anticonvulsant activity or anticonvulsant effect. A drug with anti-neuralgic action, like analgesic effect or analgesic activity, and mood stabilizer, anti-manic action. Just pay attention into anti-manic action. This link, I'm so sorry, Irina is again asking me. So to repeat the last sentence, mood stabilizer means anti-manic action or anti-manic effect. So in the case of mania during bipolar disorder, this drug will be really effective. What about the right conditions when we can prescribe this medication? Let's move to the next slide because we need to understand what does it mean British National Formulary. This is the official pharmaceutical reference book in the United Kingdom. It provides up to date evidence-based guidance on prescribing, dispensing, and administering medicines. When a text mentions World or British National Formulary indication, it refers to a specific formatting rule used in medical writing, research papers, or clinical guidelines. I'm so sorry, Irina is again asking me because the link is not working now. Irina, is it working now? Do you hear me? Okay, 3 viewers are again with us. I hope Irina is successfully joined for our webinar. So, first and foremost, seizures. Yes, carbamazepine is prescribed for seizures, for primary generalized tonic-clonic seizures, focal and secondary generalized tonic-clonic seizures, and focal and generalized tonic-clonic seizures. Also, carbamazepine can be prescribed as a prophylaxis of bipolar disorder unresponsive to lithium in adults. Plus, trigeminal neuralgia, I'm so sorry for my pronunciation again and again, in adults for sure. Diabetic neuropathy, unlicensed, I'm so sorry again, adjunct in acute alcohol withdrawal, and bipolar depression, sometimes it's effective. acute mania, psychosis, and schizophrenia as adjunctive agent. So sorry, it's my first webinar. Don't pay attention to this uh, mispronunciation. So, how the drug works: acts as a use-dependent blocker of voltage-sensitive sodium channels, interact with the opposite channel confirmation voltage-sensitive sodium channels, interacts at the specific site of the alpha pore forming subunit of voltage-sensitive sodium channels, and inhibits release of glutamate. Glutamate or glutamat, because in Ukraine we pronounce the term as glutamat. I hope that in English this term is pronounced like glutamate. You can put comments here and uh, say send me the right pronunciation if you want. Okay. So, how long until it works? Means carbamazepine. It may take several weeks to months to optimize an effect on mood stabilization. Should reduce seizures by 2 weeks, so we need to wait. And for acute mania, effects should occur within a few weeks. If it works, if our scenario will be positive, okay? The goal of treatment is complete remission of symptoms, means seizures, mania, pain, neuropathic pain means. Continue treatment until all symptoms are gone or until improvement is stable, and then continue treatment identically as long as improvement persists. Continue treatment indefinitely to avoid recurrence of mania or seizures, and treatment of chronic neuropathic pain most often reduces but does not eliminate pain, and it is not a cure since symptoms usually recur after medicine stopped. So means like reducing of the pain and total cure. It's a big difference, to be honest. And unfortunately, in psychiatry, in most of the cases, there is not a total cure. There is just a reducing of the symptoms. If it does not work, if our scenario will be not okay, sometimes it's happened, and not in some cases. In many cases, it can happen. So many patients have only partial response where some symptoms are improved, but others persist or continue to wax and wane without stabilization of mood. Other patients may be non-responders, sometimes called treatment-resistant or treatment refractory. Consider increasing dose, switching to another agent, or adding an appropriate augmenting agent. By the way, how to pronounce the term augmenting, like augmentation, augmenting, because in Ukraine we can say augmentatore, augmentacja. Consider adding psychotherapy. For sure, psychotherapy. Say hello to George, our psychotherapist in our group of intensive 2026 intensive course for preparing to crop free. Okay, it's our Ukrainian medical exam for medical insurance, especially different specialties like in psychiatry. I have our young psychiatrists who pass their exam. Luckily, they pass their exam, and that's great. Great news. So, if it doesn't work for bipolar disorder, consider the presence of non-concordance and console patient. Switch to another mood stabilizer with fewer side effects or to modify release carbamazepine. Consider evaluation for another diagnosis or for a comorbid condition like medical illnesses, substance abuse, and others. Best Augmenting combos for partial response. And yes, I'm so sorry for my pronunciation of the next main substances or drugs, psychopharmacological agents, because I know that it's like lithium. Yes, lithium plus carbamazepine, this combination is okay. What about atypical antipsychotics? Um, in this Cambridge guide, authors mentioned risperidone, olanzapine, quetiapine, and aripiprazole. Yesterday, I published my short video on the TikTok channel, Paranoically Rumba, and one user comment my video and ask me how we can combine these drugs due to their possibility of interactions. Yes, there is a high risk of interactions, and yes, the next slide will show us that yes, we can combine these drugs, but no one can guarantee us that the interaction will not happen. Sometimes interactions happen. The dosage, uh, the dosage is really influential in such case. The next combinations: valproate plus carbamazepine, but pay attention that carbamazepine can decrease valproate levels. Plus, lamotrigine and carbamazepine, the same situation. Carbamazepine can decrease lamotrigine levels. And the fifth combination, which can be used in clinical practice, is when antidepressants, especially SNRIs, are combined with carbamazepine. But please pay attention into avoiding like tricyclic antidepressants and monoamine oxidase inhibitors because it's really a dangerous situation. Don't use it. Tests before starting the treatment of carbamazepine and during treatment of carbamazepine. So we are interested in prescribing, full blood count, liver function tests, kidney function tests, thyroid function tests. The same tests should be repeated every 6 months. Plus, we must manage our weight and continue monitoring sodium levels because of the possibility of hyponatremia. Interesting fact: before starting individuals with ancestry across broad areas of Asia. Hello from Ukraine to our Asian viewers. Should consider screening for the presence of this allele. Just pay attention to this difficult title. And because sometimes these people with this allele cannot be treated with carbamazepine. Yes, sometimes it can be happen. I don't know, to be honest. Are you doing such a test in Asian countries? Because it looks like a theoretical approach, but not a practical approach. Just share your opinion in comment section. How drug causes side effects. So seen as side effects theoretically due to excessive actions as a voltage-sensitive sodium channels. A major metabolite, carbamazepine epoxide, tannin epoxide, okay, may be the cause of many side effects. And mild anticholinergic effects may contribute to sedation and blurred vision. So notable side effects is dizziness, plus drowsiness during mild fatigue, gastrointestinal, including nausea, diarrhea, edema, blood dyscrasia, including benign leukopenia, eosinophilia, thrombocytopenia, plus such a laboratory finding as hyponatremia. Plus skin reactions like rash, different variations of rash. Side effects such as headache, ataxia, drowsiness, nausea, and vomiting, blurred vision, dizziness, and allergic skin reactions are those related and are more common at the start of treatment and in the elderly. Pay attention to this period of the beginning of prescription and the beginning of including this agent into the treatment plan because this period is the most risky. Common recurrent, the same things, blood disorders, CNS disorders, gastrointestinal disorders, but others. Pay attention into fluid imbalance. we will not just stop on the slides. So, eye disorders means sensory disorder, tic, tremor, constipation, and diarrhea. Sometimes, but pay attention, uncommon. We will not waste time for this slides. You can just read and pay attention if you want. Life-threatening or dangerous side effect. Rare aplastic anemia, allonostosis, unusual bleeding, or bruising, mild fevers, infections, fever, and so on. Rare severe dermatologic reactions, like Steven Johnson syndrome, purpura, and rare cardiac problems. Then, rare induction of psychosis or mania, and syndrome of inappropriate antidiuretic hormone secretion with hyponatremia. Increased frequency of generalized convulsions in patients with atypical absence seizures. And rare activation of suicidal ideation and behavior suicidality. Pay attention, okay? What about weight gain and sedation? Weight gain is not usual, luckily. Sedation, unfortunately, is problematic, frequent, and can be significant in amount. Some patients may not tolerate it, and it's dose related. Can wear off with time, but commonly does not wear off at high doses. Senior side effects significantly lower with modified release formulation. And yes, doctors, especially in the Great Britain, as I understood, love more the modified release form of carbamazepine. What about dosing tips of carbamazepine? High peak levels occurs with the suspension formulation than with the same dose of the tablet formulation. So suspension should be generally started at the lower doses and titrated slowly. To be honest, in Ukraine, we have no suspension form of dosage. Take carbamazepine with a food to avoid gastrointestinal effects. Slower dose titration may delay one set of therapeutic action but enhance tolerability to sedating side effects. Modified release formulation can significantly reduce sedation and other CNS side effects. Yes, big love for modified release formulations. Levels vary through the day, and it is important to same through serum levels usually before the first dose of the day. Should titrate slowly in the presence of other sedating agents such as other anticonvulsants. Anticonvulsants. Let me have a look how to pronounce anticonvulsant. Okay, anticonvulsant. You will learn how to pronounce all of these medical terms during this first webinar. In order to the best tolerated sedative side effects. So can sometimes minimize the impact of carbamazepine upon the bone marrow by dosing slowly and monitoring closely when initiating treatment. Initial trend to neutropenia may reverse with continued conservative dosing over time and allow subsequent dosage increases with careful monitoring. The next dosing tips. Carbamazepine often requires a dosage adjustment upward with time, and the drug induces its own metabolism, thus lowering dose over the first several weeks to months of treatment. Carbamazepine modified release tablets at this will alter the controlled release properties. Yes, don't choke. Chow, how to pronounce this word in English. Plasma level of higher than 7 milligrams per liter may be required in effective illness. Levels higher than 12 milligrams per liter are associated with higher side effects burden. How to dose such rules? Immediate release and modified release. Just pay attention into these different rules. So initial oral dose from 100 milligrams to 200 milligrams 2 times per day, and increased by increments of 100 to 200 milligrams every 2 weeks. So we can increase the dosage every 2 weeks. Usual dose It's varied from uh, 800 milligrams to even 1 2 gram per day in divided doses. So the maximum is even 2 gram per day in divided doses. Modified release initial oral dose from 100 to 400 milligrams per day in 1 2 divided doses, and the same rule for increasing the dosage is working. What about the usual dosage? It's the same situation as with the immediate release of this drug. What about the next? Trigeminal neuralgia, the best word combination of this webinar. So initial oral dose is like recommended 100 milligrams for 1 to 2 times per day. Some patients sometimes may need higher initial doses. Increase gradually according to response, and usual dose is 200 milligrams 3 or 4 times per day. What about initial oral dose for modified release of carbamazepine? From 100 to 200 milligrams per day in 1 or 2 divided doses. The same thing, some patients may require higher initial doses. What about usual dosage range? Like the same thing is, it can be looked as the same thing as the immediate release. The maximum is the same, but what about the range of initial dose? It's like the huge difference is in frequency, okay? Because usual dosage in modified release is like can be divided in 1 or 2 times. What about the usual dosage in immediate release? It must be divided in 3 and 4 times per day. Just pay attention to this difference. Prophylaxis of bipolar disorder unresponsive to lithium. Unlucky case, to be honest, for psychiatrist. Look at these dosage ranges. Yes, they're not so low. So initial oral dose is 400 milligrams per day in divided doses, increased until symptoms are controlled, and the usual dose is from 400 to 600 milligrams per day, and maximum is 1.6 gram per day. Initial dose of modified release carbamazepine is the same, like 400 milligrams per day in 1 to 2 divided doses. Increased rules are the same, and usual dose is from 400 to 600 milligrams per day in 1 2 divided doses, and maximum is 1.6, the same maximum, gram per day. Joint in acute alcohol withdrawal. Say hello to Marta. How to pronounce your in English? I hope my pronunciation is right in this case. So she was a specialist with like dependence with different types of dependence. So immediate release. We are interested in prescription of immediate release, and initial oral dose is 800 milligrams per day in divided doses, then reduced to 200 milligrams per day for usual treatment duration of 7 to 10 days. Used gradually over 5 days. So pay attention into this reducing of the dosage, because in the previous cases we need just to increase the dosage, but in this case we should reduce the dosage. Diabetic neuropathy for neurologists. Maybe this slide will be interesting. I hope you will read this slide without my reading. Then, what about children and adolescents? Yes, say hello to pediatricians or child specialist in psychiatry. Prophylaxis of bipolar disorder, we are interested in immediate release of carbamazepine. And child from 1 month to 11 years, initial dose either 5 milligrams per kilogram per day at night or 2.5 milligrams per kilogram twice per day, then increased by increments of 2.5 milligrams to 5 milligrams per kilogram every 3 or 7 days as needed. Maintenance 5 milligrams per kilogram from 2 to 3 times per day, increased as needed to 20 milligrams per kilogram per day. What about child? Can we call it like child because it looks like a teenager or adolescent? From 12 to 17 years, initial dose is 100 from 100 to 200 milligrams, from 1 to 2 times per day, then increase to 200 to 400 milligrams to 3 times per day slowly. Increase is needed up to 1.8 gram per day. What about such a horror overdose? Okay, sometimes yes, it can happen and it can be fatal. Lowest known fatal dose in adults is 3.2 gram, in adolescents is 4 gram, and in children is 1.6 gram. What about symptoms? Vomiting, nausea, involuntary movements, irregular heartbeat, urinary retention, trouble breathing, sedation, and coma. Give repeated doses of activated cortical by mouth. To be honest, I don't know how to pronounce cortical. In Ukraine, we say активоване вугілля. Long-term use may lower sex drive, monitoring of liver, kidney, thyroid functions, blood counts, and sodium is advised. What about habit forming? Luckily, no habit forming for carbamazepine. How to stop this drug? Taper, stopping. So sometimes this rule is really important. In most of the cases, to be honest, may need to adjust dosage of concurrent medications as carbamazepine is being discontinued. Rapid discontinuation may increase the risk of relapse in bipolar disorder. Plus, epilepsy patients may have a seizure upon withdrawal, especially if withdrawal is abrupt. So, discontinuation symptoms are uncommon, but tapering is more better. Okay. Pharmacokinetics, metabolized in the liver primarily by cytochrome P. Half-life is 36 hours after a single dose. Half-life is from 16 to 24 hours with repeated doses. Active metabolite is carbamazepine 10 and 11 epoxide, zero of side effects. So it's not only subscribed for cytochrome P 450 3A4, but also its inducer of the same ferment. Thus, carbamazepine induces its own metabolism, often requiring an upward dosage adjustment. It's also an inducer of cytochrome P45 2C9 and weakly of cytochrome P45 1A2 and 2C19. Food does not affect absorption, luckily. What about drug interaction? I think it's the most fascinating part of this webinar. Carbamazepine reduces plasma levels of most antidepressants, most antipsychotics, benzodiazepines, some cholestyramine inhibitors, methadone, thyroxine, theophylline, estrogens, and other steroids may also be reduced, resulting in treatment failure. Drugs that inhibit cytochrome P 450 3A4 will increase carbamazepine plasma levels and may precipitate toxicity, as cimetidine, diltiazem, verapamil, erythromycin, and some accessories, including fluoxetine. Patient requires contraception will need to be on higher doses of estrogen or use non-hormonal methods. Depressive effects are increased by CNS depressants like inhibitors of monoamine oxidase, is the most favorite pharmacological group of antidepressants. It's like a joke. Don't pay attention. And other anticonvulsants. Because carbamazepine is structurally similar to TCAs, in theory, it should not be given within 14 days or discontinuing of now inhibitors. Combined use of carbamazepine and lithium may increase risk of neurotoxic effects. Combined use of carbamazepine, a suspension with liquid formulations of chlorpromazine. I'm so sorry. I mean out of bucket days. We also know this drug as aminazine, as a brand name, has been shown to result in excretion of an orange rubbery precipitate because of this combined use of carbamazepine suspension with any liquid medicine is not recommended. Such great effect. Enzyme including anti-epileptic drug, carbamazepine itself, as well as phenylbutyl, phenidine, and primidone, may increase the clearance of carbamazepine and lower its plasma levels. Pharmacodynamic interactions can also occur. Anticonvulsant activity of carbamazepine is reduced by drugs that lower the seizure their hold, so antipsychotics and antidepressants. Potential of carbamazepine to cause neutropenia may be increased by drugs that have potential to depress the bone marrow, such as clozapine. Risk of hyponatremia may increase by other drugs that have potential to deplete sodium, like diuretics. Rarely, neurotoxicity have been reported when carbamazepine is combined with lithium. Other warnings and precautions. Patients should be monitored carefully for things of unusual bleeding or bruising, mouth sores, infections, fever, or sore throat. In the risk of aplastic anemia and granulocytosis with carbamazepine use is from 5 to 8 times greater than in general population. Risk in the untreated general population is 6 patients per 1 million per year for granulocytosis and 2 patients per 1 million per year for aplastic anemia. Or anemia, I'm so sorry. Leukopenia that is severe, progressive, or associated with clinical symptoms requires withdrawal if necessary under cover of a suitable alternative. Use with caution in patients with a history of hematological reactions to other medications. Use with caution with patients with cardiac diseases. Caution with skin reactions. Because carbamazepine has a tricyclic chemical structure, use this caution with MAO inhibitors, including 14 days after MAO inhibitors are stopped, follows the expert. May exacerbate angle closure glaucoma. Because carbamazepine can lower plasma levels of hormonal receptors, it may also reduce their effectiveness. May need to restrict fluid intake because of risk of developing syndrome of inappropriate antidiuretic hormone secretion, hyponatremia, and its complications. Used with caution in patients with mixed seizure disorders that include atypical absence seizures, because carbamazepine has been associated with increased frequency of generalized convulsions in such patients. Even for viewers, thank you so much. Thank you so much. It's very kind of you, my dear viewers. So, may exacerbate absence of myoclonic seizures, warn patients and their caregivers about the possibility of activation of suicidal ideation and advise them to report such side effects immediately. Carbamazepine is associated with anti-epileptic hypersensitivity syndrome, cross-sensitivity reported with oxcarbazepine and phenytoin. Consider vitamin D supplementation in immobilized patients, where those with inadequate sun exposure or dietary calcium intake. Please don't use carbamazepine in such a case with patients if this patient has a history of bone marrow suppression, if patient has a parachromatoma, if patient have an anteroventricular conduction abnormalities, if patient have a positive of this allele individuals from Asia, say hello for viewers from Asia, if they are present here. Suspension in patients with hereditary problems with fructose intolerance. If there is a proven allergy to any tricyclic compound, if there is a proven allergy to carbamazepine, for sure, we can't use carbamazepine because there is a proven allergy. What about pregnancy? Available data suggests an increased risk of congenital malformations. The absolute risk is estimated to between 3.8 to 6.2%. Risk of major congenital malformations is dose dependent. Exposure in pregnancy is associated with malformations in the urinary tract and respiratory system, neural tube defects, and other specific malformations. Available data doesn't suggest an increased risk of neurodevelopmental delay, but limited data means this cannot be excluded. Limited data on prenatal death, low weight for gestational age, preterm delivery, and intensive care requirements mean risks are uncertain. Use in women of childbearing potential requires weighing potential benefits to the mother against the risk to the fetus. For bipolar patients, carbamazepine should generally be discontinued before anticipated pregnancies. If drug is continued, we perform tests to detect birth defects. If drug is continued, start on later 5 milligrams per day early in pregnancy to reduce the risk of neural tube defects. Use of anticonvulsants in combination may cause a higher prevalence of teratogenic effects than anticonvulsant monotherapy. Type of drug is discontinued. Seizures, even mild seizures, may cause harm on the embryo fetus. Recurrent bipolar illnesses during pregnancy can be quite disruptive. For bipolar patients, given the risk of relapse in the postpartum period, some form of mood stabilizer treatment may need to be restarted immediately after delivery if patient is unmedicated during pregnancy. But in the future, we will discuss about breastfeeding. It's like controversial. Antipsychotics may be preferable to carbamazepine if treatment of bipolar disorder is required during pregnancy, and bipolar symptoms may recur or worsen during pregnancy, and some form of treatment may be necessary. Breastfeeding, finally. We move to this slide. Significant amount found in mother's breast milk. Some cases of neonatal seizures, respiratory depression, vomiting, and diarrhea have been reported in infants whose mothers received carbamazepine during pregnancy. If drug is continued while breastfeeding, infants should be monitored for possible adverse effects, including hematological effects. If infant shows signs of irritability or sedation, drug may need to be discontinued. Bipolar disorder may occur during the postpartum period, particularly if there is a history of prior postpartum episodes of either depression or psychosis. Relapse rates may be lower in women who receive prophylactic treatment for postpartum episodes of bipolar disorder. For bipolar patients, consider first-line choice for use during breastfeeding, and antipsychotics may be preferable in some circumstances during the postpartum period than breastfeeding. So, one of the final slide is the art of psychopharmacology. What about potential advantages of carbamazepine? This drug can be prescribed when a patient has a treatment-resistant bipolar and psychotic disorder. What about potential disadvantages? Patients who do not wish or cannot comply with the blood testing and close monitoring. So we must control blood laboratory testing every 6 months and it's necessary. And if patient is not able to do it, just think is it necessary to prescribe carbamazepine or we will have another option. Patient who cannot tolerate sedation. Yes, unlucky sedation patients. The information was and first and foremost, yes. Carbamazepine is not recommended for pregnant women and for the period of breastfeeding. Primary target symptoms: it's seizures, it's pain, especially neuropathic pain, unstable mood, especially mania. I will repeat this, uh, like this slide as one of the first slide about maniac state of bipolar disorder. It's necessary to remember. And finally, fears. Carbamazepine was the first anticonvulsant widely used of bipolar disorder, but has not been shown to be as effective as lithium in prophylaxis. So, if you compare carbamazepine and lithium is a little bit better. A modified release formulation has better evidence of efficacy and improved tolerability in bipolar disorder than just immediate release carbamazepine. Dosage frequency, as well as sedation, diplopia, confusion, and ataxia, may be reduced with modified release carbamazepine. Risk of serious side effects is greatest in the first few months of treatment. Common side effects such as sedation often abate after a few months. So the first months are the most difficult for us. May be effective in patients who fail to respond to lithium or other mood stabilizers. May be effective for the depressed phase of bipolar disorder and for maintenance in bipolar disorder. Interactions with concomitant medication, including the oral contraceptive, can make this treatment difficult to manage. My dear viewers, thank you so much for being here. Please write comments who you are, just your names. Maybe it's like our psychiatrist medical interns, our future psychiatrists. In 2 weeks, you will become a psychiatrist. Psychiatrists, like independent practice. I'm waiting for your comments. Please comment this webinar, who you are here. Just write your names because it's so interesting. My first 3 viewers of my first YouTube webinar in English. Was it real hard with my pronunciation? Maybe 3 ones because I am from another account, and only 2 ones. Just write your names, please. This Jim Bim was great. Thank you. Oh my God, for ignorance here. Where are you from? Mr. Jim Bim, where are you from? Are you a psychiatrist or a medical psychologist or a medical student? Plus, what about another one? Another one. Please don't be silent. Just write your name. It is so interesting to understand who you are. Because it's my first webinar. You're like my like my heroes here who are listening to me, who are listening to this webinar. Irina, I'm here by the way. You listen to me because the connection was not stable. You informed me before. Anyway, another person is anonym. Plus one person is again here. Please write your names because it's too interesting for me to know who is here. Oh, Karina! Karina from Odessa, are you here? Okay, maybe this anonym will write me and share the secret with me, who is here. Anyway, thank you so much. The translation, I think, can be finished. Thank you again. Thank you.